Hello, sophomore students. Hope you all are doing well today. I decided to make a video PowerPoint for the heart and the neck vessels for the examination part. You can review this on your own before class next week so that you are good to go. In class, we'll be going over a little bit more of the anatomy than we usually do because I feel like the anatomy and physiology of the heart itself is very important to ensure success when you're doing your assessments. So first thing, of course, that we're going to look at is the subjective data. These are some things that you can start looking at page 471 in your textbook and follow along. And these are things that you're going to ask about. Chest pain, and in your book there are certain questions that will help guide you to ask more effective questions when it comes to talking about chest pain, such as onset of pain, character, grading the pain, how severe is it, does it radiate anywhere, all of those things that we learned about with pain already, but a little bit more specific to the heart. Dyspnea, you know, is shortness of breath or difficulty breathing. So we want to ask about that. When you ask about the shortness of breath as well, you want to know from the patient if there are certain things that make the shortness of breath worse. Are certain activities, or is this when they're just laying down or sitting in their chair relaxing and they feel it? So all of those things need to be asked. Orthopnea, this is where a person has more difficulty laying down with breathing than they do with sitting up. So orthopnea is the ability to be able to sit up and be able to breathe better. And that's not a normal finding with anybody. So we need to ask more questions about that. Cough. Cough can be important because people with congestive heart failure and who have a lot of fluid built up in their lungs and around their heart may develop a cough. Also could be related to some of the heart medications that they're taking. Fatigue, obviously, cyanosis or pallor. Edema, this is important, as we know, because depending on what side of the heart is being affected, or it could be both sides, we may see swelling in different areas. And we'll go over that a little bit more in our lecture in class. Nocturia, again, goes back to that buildup of fluid, so they feel like they have to get up several times a night to urinate. If they've had a past cardiac history or family cardiac history, that's really important. And then personal habits that can be cardiac risk factors, such as smoking, drinking, drugs, you know, different things like that. So stuff that are things that are specific to their personal habits. So questions, again, any chest pain or tightness, look at page 471, again, talking about onset, location, character of the pain. Make sure you read through all of those so that you understand that. When you assess your partner in lab, you're probably not going to find a lot of abnormal findings on your mostly probably healthy lab partner, but it's important to understand the rest of these questions so that when you get out into working in clinical and as your future careers as nurses, you're going to need to be able to understand that. Angina, what is angina and how is it different from a heart attack? I'll let you think about that for just a minute. So angina itself is just chest pain, and how it differs from a heart attack is that it usually subsides on its own. It usually, you know, it kind of comes and goes. It's not a consistent, constant pain. And the biggest key here is if a patient has angina that they already have been diagnosed with, they probably have a prescription for nitroglycerin tablets, which we know can be used for angina or chest pain. So, and nitroglycerin will help the symptoms of chest pain subside for angina, whereas it won't help if the person truly is having a heart attack. Dyspnea questions, again, shortness of breath. Look at the questions on page 471. We talked about orthopnea already. We talked about why a person may have a cough associated with the cardiovascular system because of that fluid buildup around the heart and possibly in the lungs as well. Cyanosis or pallor, what causes this? Obviously, this would be because of a decreased blood flow to the surrounding tissues, so and mostly to the peripheral tissues. Now, what I want you to remember when you think about the word peripheral is when we talk about peripheral regions on the human body, we're talking about all of the areas that are away from the trunk. So our trunk from, and the head could be included with the trunk as well, but to our waist. So we're basically talking, when we say peripheral, we're talking our extremities, our arms and our legs. So if we're looking for peripheral edema, we're looking in our arms and our legs. If we're looking for peripheral cyanosis or peripheral pallor or again, peripheral edema, then we're going to be looking in the arms and legs. Bilateral versus unilateral edema. Why might a person have edema? Bilateral versus unilateral. If you look at page, oh, I'm sorry, hold on. Sorry about that. I was looking at the wrong page and I wanted to make sure I had the right page number for you. So if you look at page 472, towards the bottom in the blue column, talking about rationale, it talks about bilateral versus unilateral edema. And you see more bilateral edema with patients who have cardiovascular disease. When they have unilateral edema, that's typically more something within the peripheral vascular system, usually a vein that's having, that is the cause of that. So, so remember when you're looking at that, if you have bilateral, that's more significant for cardiovascular disease. And then again, we talked about nocturia. These are some questions. These are found on page 473 that you want to ask about. These are all kind of important questions, especially that first section where you're talking about history of hypertension, elevated cholesterol, heart murmur, any of those things that the patient may already have a history of. And then to the last one too, we're also looking at the family history, because we know that sometimes when it runs in our family, we're at a greater risk as well. So asking all of those questions. And then personal habits. These are all cardiac risk factors. One word I want you to think about here is called patient-centered care. So we want to focus on the patient and we want to focus on the issues related to them. So all of these things are specific to just the patient. What is their nutrition like? Do they eat healthy? Do they eat lots of fruits and vegetables and greens? And you know, do they get enough protein? Do they get enough carbohydrates? Or, you know, do they limit those things the way that they should be? So, or are they eating a high fat diet? Are they eating a diet high in fat and cholesterol? That would be specific to the patient. And of course, other risk factors that we know about are smoking, alcohol, and the use of drugs. And then how much do they exercise? And we always have to think about exercise being separate from what we do on a normal basis. So if we walk back and forth in the hallways of the hospital on a normal basis every day, we can't count that as exercise. We have to go above and beyond what we normally have. So think about that when you ask these questions to your lab partners and again in the future with your patients. Preparation and equipment. Mostly what you need to do is you need to have a stethoscope. Sometimes you might want a little ruler or a marking pen, but other than that, your stethoscope is your most important piece of equipment. So palpating the carotid artery, you can get a lot of information on cardiac function just from doing this. We know it's medial to the sternomastoid muscle, so if we turn our head and here's that sternomastoid, it's medial towards in between the trachea and that. Remember, only palpate one side at a time. We can decrease blood flow to the brain, and then that can cause patient to become dizzy and even pass out. Feeling the amplitude of the pulse, normally we know it's a 2+. So just as we've been assessing pulses around in the different areas of your body, we're going to be assessing the carotid as well. And as always, the findings should be the same bilaterally. Auscultating it, we're listening to make sure that it just sounds nice and controlled. Is it that regular rhythm? When we listen to it, we're going to use the bell side of the stethoscope, and we're not going to press really hard. We're just going to press kind of lightly up against it. One thing that we don't want to hear is something called a bruit, and this is a blowing or swishing sound, and it's means that there's some kind of turbulence in that area. So I like to think about where maybe three rivers come together and we have a turbulent area where the three rivers meet. And that can be, that if you can picture that and kind of put a sound to what that might be like, that's what you're going to hear with the bruit. So lightly apply the bell, 3 different places. The picture's in your book for this, so you can look at that. At the angle of the jaw, the mid-cervical area, and then at the base of the neck as well. And that picture is found on picture on page 476. You'll see a patient that's having auscultation, and they've labeled the 3 areas for you. We already talked about don't compress the artery. Compressing it too much can also cause a bruit, so making sure we don't do that. And the second thing is something that's really good to note, that you should have the person take a breath in, blow it out, and then hold their breath. So don't take a deep breath in and hold it, but they hold their breath after they've exhaled. If you're holding your breath when you inhale, some of the muscles over the scapula will tense up, and then that can make it harder to hear the carotid arteries. Sometimes you can hear normal heart sounds transmitted in the neck, but again, don't confuse these with the bruit. So lots of practice to get used to this. This is just a picture. This picture is from your book as well, and it talks about, I don't have the page right in front of me, but it's in the beginning of the chapter, and it's just showing you all of the different areas and where the sternomastoid muscle is, and the different places that you can find those arteries. All right, the precordium. Precordium is also known as the chest area that lies over the heart and the great vessels. So you will hear precordial pain. You'll hear about placing electrodes if you're doing an EKG on the precordium. We have precordial leads when we do that. So a good word for you to remember is the word precordium. Precordium, again, is the chest area that lies over the heart and the great vessels. So again, when we're inspecting using that tangential lighting that we've talked about coming from the side, we're looking for pulsations. You might actually see lifting from the pulse over the chest wall. Usually found in the 4th or 5th intercostal space at that midclavicular line. We're going to go over this a little bit more in class, but if we went the intercostal spaces are the spaces between our ribs. So if we counted down to the 5th space and we went about mid-clavicular line and drew a straight line down, that is where we might see it. Harder to see in women because of the breast tissue or somebody who is obese. Usually you can see it in children and sometimes